I'm just starting to move towards the functional medicine paradigm. I'm doing the AFMCP at the end of March, and I'm also just about to start the Functional Medicine Coach Academy course as a health coach. So I'm not a GP. I'm wondering, is there any issues with getting insurance or scope of practice for somebody who isn't already a GP who wants to move into this?
Sure. Okay, I think, do you want to start with that, Ayan?
Yeah, I mean, in fact, I don't know if you can hear me, sorry.
Probably.
That's better, brilliant. I was going to say you're ideally placed, actually, because having a background in osteopathy means that you're already in that model of working holistically, and as we know in osteopathy, I always refer to osteopaths as doctors who actually sort of know how the body works but don't know much about drugs, which is not a bad thing. And many functional practitioners that I know came from that background, and actually you're better placed, I would say, than most NHS GPs, and you wouldn't have that conflict either of that I have that we've been discussing tonight already, you know, about, oh, can I test for this in the NHS or not? Because it's very explicit that you work outside that system, so go for it. I mean, there's absolutely no problem at all, and in fact, you'll probably more intuitively, you'll find that AFMCP fits your model much better than a lot of doctors where, you know, even though I've been in this model of integrated medicine, I think when I went on the AFMCP, I was scratching my head a bit thinking, hang on a second, this is completely the opposite of what we've been doing for years, whereas it won't feel like that for you. So, you know, it's, you know, go for gold, I'd say.
You just need to use the mic, because otherwise all the people at home can't hear.
And with the testing part of it and
sure.
Getting access to those tests?
Really straightforward. I mean, that was something that scared me, actually, because I'm used to working with NHS lab tests, and actually you get there and you think, oh my God, these nutritional therapists, they know so much more biochemistry and physiology than I do, in the sense that we don't use that as much on a day-to-day basis in general practice. But actually the tests are very logical, and the companies that provide those lab tests, the support that you get is amazing. I mean, if you go onto the website of any of those companies and actually look at the sample lab reports, you can do a lot of the learning from there. I'm not saying that that's what you should do, but the backup is incredible, completely different to what we're used to in NHS practice. So don't be scared by that. It's very logical, and you're taken through it really well on AFMCP.
I'm just going to take one question from Swiss. We've got Amy Sapola, a pharmacist, who is delighted to hear the focus on interdisciplinary teams as a way of moving forwards. And she's a pharmacist, and she's highlighting the role for pharmacists in helping. I just wonder if any of the panel have had any experiences where pharmacists can sort of add value to functional medicine and lifestyle medicine.
I can contribute, because I honestly think in mental health services, pharmacists are a very underused resource. And I mean, the way we use is often, I mean, I mentioned about side effects and medication withdrawal, and the existing evidence is buried again, you know, under heaps of pharma-driven research. So when I work with patients who, in whom I cannot differentiate whether this is a relapse of their original illness or a result of a medication which sometimes, you know, they have stopped weeks, if not months ago, I use a pharmacist a lot to correlate that with the evidence. But also, it's very interesting that even after becoming a consultant, I realized that some of the things that you learn on the job might be entirely wrong. So one example is medication taper. Antidepressant medication taper is a very individualized process. And again, I find the input from pharmacists invaluable in, you know, in discussing how to personalize that to patients to make it, you know, safe and tolerable, and also withdrawing. And I mean, you said about a small list of medication that we use. I think my interactions with pharmacists have taught me that you can do a lot of harm with a very small list as well. And actually, the slide that I showed about side effect reporting is something that a pharmacist shared with me. So it was not something that was taught to me during my training or through practice, but it was pointed out that this is where I need to input.
That's fantastic, and it really sort of again, utilising the skill sets of another healthcare professional, and most GP teams actually have pharmacists either sort of very close or closely, there's close relationships, and I think they can add a lot of value because, you know, to be very clear, functional medicine approaches are not anti-medication, okay? It's about the appropriate use of medication for the right patient rather than the blind sort of over-medication and over-suppressing of symptoms. So there is a role for pharmacists, I think also, but also for deficiencies in certain nutrients that can come about. Sarah, you had something to add?
I had a patient recently who I would have loved some pharmacy support for. She was a lady with epilepsy, and she'd been through every anti-epileptic drug known to man. She's ended up on one that was clearly still making her very sick, but because it was controlling her epilepsy, the neurologist wanted to leave her on it. And one of the things I've been doing recently is looking at the genomics, so looking at the detox pathways. So I was able to do that with her and see where she had SNPs that were perhaps uniquely changing her ability to get rid of the toxic byproducts from her anti-epileptic drug. And oh my goodness, it just took me days to try and figure it all out and work out why it was that this lady was getting so sick. But it was possible to do, so I could then give the evidence back to the neurologists and say, actually, you really need to change the dose of this lady's medication. She can't cope with it. It's giving her metabolic acidosis. But a pharmacist would have been an amazing asset in that situation.
I just want to add to that, Rangan, is that pharmacists have become really interesting and vital parts of the functional forum meetup groups. Yeah. And one of the cool things that I've heard is actually that a pharmacist or a pharmacy is actually quite a good location to have these groups because everyone's using it. There's typically a bit more space than there are in other places, bigger waiting room. So we have maybe a dozen, if not more, meetup groups that are hosted in a pharmacy and have pharmacists there. And typically one pharmacist who gets it will be a really great resource for potentially a dozen physicians in the community who want to, you know, have a relationship like that there. So if you're starting a meetup group, call the local pharmacists and get them involved because it adds a lot of synergy to everyone else.
Yeah, great. Just one more from Twitter, then I'm going to come to you guys here. I've got an Isabella Natrins watching. She's not in the crowd, is she? No, she is on Twitter. She's definitely tweeted. She is saying that people have forgotten how to cook, so how are we going to make a difference? Okay, and really that got me thinking it's a very, very good point, and that goes beyond the role, or the conventional role, I should say, of a GP practice. And I wonder, does anyone on the panel have a view on that, as to whether there should perhaps be a cooking school in every general practice?
Well,
Sarah?
I some time ago went through the full paleo autoimmune protocol with 2 small children and a fairly reluctant husband. And the amount of cooking that was required for that, to do 4 weeks completely free from everything, yeah, I would have really appreciated some support there. Yeah, so if someone could have taken me to a nice class and shown me, but actually as a clinician, having been through that process, and basically living a fairly paleo diet now, I'm actually my own best resource in terms of helping patients, although it's quite time consuming for me and it would be really nice for me to have a health coach to do that instead, but at least I understand what patients are going to have to go through to do that process.
There's lots of published research echoing that physicians, healthcare professionals are much more likely to recommend treatments or therapies if they have been through them themselves. And I know certainly for me, that's very much been the case. And I try and live and breathe everything that I that I preach to my patients. And I think that's important. I really do. I think if we're going to talk about the field of lifestyle medicine, I think where possible, we should be, not should be, but if we are applying those, I think we're much more likely to not only to tell our patients about them, but to really present it in a way that actually engages them so they actually make a change when they walk out the door. Because it's all right telling them. The other thing I was just going to pick up from Sarah's talk is her comment regarding, you know, the assumption within certain healthcare professionals, but particularly I see it in my profession, but you know, the patients won't listen. Well, really? it's quite a big assumption to make that our patients won't listen. And, you know, practicing this kind of medicine, it's fun. Patients do listen. Patients want this information. But yes, it's hard in the current system, which is obviously why we're talking about how to integrate it into this current system. James?
Yeah, I was just saying, you know, it's a critical role, and one of the things that we've seen and why we came up with this concept of the functional micro-practice, I think if all of us just sort of like take a moment to do a vision board of what the perfect wellness center clinic looks like, it's definitely got a teaching kitchen, right? We'd love to see that. But what we see is also the wreckage of the fact that everyone has this amazing idea, and then you have to like start to implement it, and then you have to work out the business model and how's it going to be used, and it sounds good until you're the owner, operator, the HR, and all of these different pieces at the same time. And so many in functional medicine 1.0, so many practices failed because they tried to do everything, and they just assumed that if you got a team of practitioners, made them all independent contractors, it would be one big happy wellness family. And the truth is, it doesn't happen like that. The successful practices that look like that at the end typically have a really core service that they get very good at in a low overhead environment, where they work out what is the engine of this practice, and it's a team working together. And then once they have a really good client base and they've built to a certain degree, they see, okay, we've got dozens of people on the books that we can communicate to, we know who they are, who are ready to do these cooking classes, and then they make the jump to the slightly higher overhead. And, you know, I think that that's one thing to take into account. You know, that just to go back to your point here, the biggest problem I think that you're likely to have is not like the clinical side, because like Ayan said, you have to unlearn the least to do this the most effectively, but it's the non-clinical aspects of running this practice that has caused really not the stagnation, but the potential for acceleration in the more advanced nations like America in this space have been hampered by the non-clinical aspects of business development. And so I would just encourage everyone that is a great vision to have these practitioners working together, but there are plenty of cooking facilities that you don't have to own or rent to be able to make this kind of impact. And just to think about that as you're designing your perfect clinic.
Whoa, lots of questions. Okay, yeah, sure.
Going.
Let's go. Hi.
Thank you. Well. Yes, my name is Mike Murphy. I qualified as a nutritional therapist in 2015, and last year I exited a 30-year IT career to start my own nutritional therapy clinic. I had a dinner party a few weeks ago, and one of my friends is a senior medical doctor in the NHS on the critical care side, and incredibly dismissive of nutritional medicine. I'm wondering, do you have any advice? Rangan, this question is for you. Do you have any advice for nutritional therapists
on how TV shows he could watch?
On how to engage as a nutritional therapist with doctors of that mindset?
Okay, so you're talking about someone who may have a closed mindset already, and I think in whatever aspects of life we're talking about, that can be quite a challenging sort of engagement to make. I'm going to I'll come back to that, but I'm just going to go back to when I spoke in Edinburgh in November, and I'll explain the relevance in just a second, but I was speaking at the medical school where I was a student, and it was remarkable for me in this packed auditorium that actually some of the doctors who taught me as clinicians were still there in the crowd, and they were still working at the Royal Infirmary of Edinburgh. And I felt like a little boy actually being on stage in front of people who would teach me medicine not that many years ago. And at the end, there was a Dr. Graham Nimmo, actually, and he is someone who's been teaching advanced life support to all the sort of senior house officers come through. He sort of runs all the cardiac arrest teams. He's been an intensivist for many, many years. He was a consultant intensivist when I was at medical school, and he's still there. And he came up to me afterwards, he said, I buy into everything you just said. I'm going to send you some stuff about how this sort of medicine is relevant in the intensive care setting as well. And whilst this doesn't directly answer your question, it's just to add that there is hope, actually. There are people out there who are open-minded. There are, I'm guessing that he is probably sort of early, mid-60s potentially, in terms of he's been practicing for a long period of time. But if you've been practicing for long enough, you start to see where the ceilings are in terms of what we can do. how do you start that conversation? It's very difficult. It is very difficult. I can't really guide you in terms of what you do in that setting, apart from explain your position as professionally as you can. If they're not willing to listen, from my perspective, I think it is quite challenging. Have you got anyone can add to that?
Yeah, I mean, I'd like to say that there's a number of issues there, because obviously that person's world is downstream medicine, so he's sort of seeing people who've been scooped up after they've been run over by a bus or whatever, you know, the acute stuff. And I think if you're in that environment for a long enough time, you start to think about people who go gluten-free as being a little bit difficult or crazy, because that's not his world. The other thing, of course, is, you know, if he's like a traditional doctor and he knows that you're a nutritional therapist, he may not even know what a nutritional therapist is. I mean, he's obviously a friend of yours, so I'm hoping he's got some idea. It's hard enough peer-to-peer, doctor-to-doctor to convince colleagues that work in hospital that there is validity in this model. And I'll tell you the thing that really sells it to these people. It's when they become ill themselves and they sort of realise that the medical model's broken. It works for some people. I find it very hard in the NHS when, you know, someone's been off to the rheumatologist and they feel a lot better on an immunosuppressive drug. It's like, oh yeah, my joints feel great, I'm on methotrexate. And you know, I have that conflict, the same as these guys, you know, as Sarah, where I think, oh, you know, how much time have I got and how can I pull this back? But actually, you know, most of the time I'll say, hang on, well, that's fine, you know, if you feel better, that's great, you know, and I'll see you again in 6 months' time or whatever. So I think it's a case of just constantly chipping away, and, you know, if he's interested, he'll find out and he'll learn, but he may never do, and a lot of people don't, and that's fine as well. You know, it's not every battle is worth fighting.
Yeah.
Thank you. Hello. Okay. I don't know if I can add just one small thing to your question, because by the way, my name is Raphael. I'm an internal medicine trainee in Edinburgh, Scotland. I'm applying for endocrinology next year. There is a huge percentage of people presenting to A&E with disorders which have no cause. So if you want to convince an acute medical or an A&E practitioner to look into this kind of stuff, say, well, how many of your patients are functional? Chronic abdominal pain, chronic pelvic pain, chronic shortness of breath. These are people who A&E see week after week presenting. You look at their list of admissions, they present 20 times a year. So mention that. Anyway, my question is mostly, I think, addressed at Dr. Davies. I was very interested to come to this talk because of the title, NHS. A significant proportion of our patients might not be able to afford a private consultation. So, you know, people come in hospital, classic patient coming with an acute exacerbation of their multiple sclerosis, and you see a 2-liter bottle of Coke on the table and a McDonald's sitting next to it. So for those patients, how do you go from their model of life to a functional medicine? You know, how do you essentially, when you mentioned resources, how do you go there? How do you start a conversation? Where do you point them? Because that is something I struggle with. What resources do I use? Where do I point these people?
Right, well, the first thing is to really start at the beginning and listen to the patient. You need to find out where they are and form a bond with them. No one is going to change their diet and lifestyle unless they have a connection with you. It's a really hard thing to do. And so they have to trust you. So you need to spend time with that person and you need to understand where they are. Maybe that lady with MS has a bottle of Coke on her bedside table because someone's bought it as a gift because she's in hospital. You can't always make assumptions about people. And the other thing is really finding out what it is that specific person needs. It might not be that the thing that they need is a full overhaul of their diet and lifestyle. They may not be somewhere where that's an option. It may just be that actually their mental health needs fixing first, that they need psychological help, and that then when they're feeling better, they would be motivated to perhaps try something else. So never make assumptions about patients. always find out where they are, and then you can find out what the most appropriate intervention is. And if you listen, you will be able to.
Yeah, I'd just like to add to that. We had Dr. Terry Walls on the Functional Forum in September, and she's not in practice. She's a researcher practicing inside the VA and in the Veterans Administration. So this is a very limited budget. And so she now is delivering, everyone goes through the functional medicine assessment, but it's working with a functional medicine doctor and RD together. But all of the care is delivered in groups. And she had an amazing quote, we have it as a meme going around online, which is basically that now that I've done this, working in groups, the aha moments, all of that stuff is so powerful that I'll never do it singularly again. So it's the most efficient use of doing it. And I would say the person that teaches them to stop drinking Coke and maybe the McDonald's might not be the doctor, but if you set up a system where there's another patient who's getting better with MS who says, oh, you got to get rid of that stuff. The first thing I did was get rid of that stuff and I felt better. Oh, what, you had MS and now it's improving because of that? That is really powerful. And we're in such a good position to put those people together. They literally categorize by disease, and if not disease, then disease, categorized by the underlying pathology. In America we see group visits where they're doing not group visits based on the histology of the disease, but actually the root cause. So if you've identified that there's gut permeability in this lupus patient, this MS patient, and this rheumatoid arthritis patient, they can be really powerful in a group together because essentially the same insults are just causing a break in the chain depending on the genetic vulnerability of the different people. And so I would highly encourage, as you start to think about how this can be rolled out, I mean, to me, it seems likely the functional medicine operating system will be rolled out in the NHS in a group format. It just seems the most likely to me because groups visits always starts as a resource constraint. And then when people actually do it, they're like, actually, there's some magic here that is not possible in a one-on-one intervention. So if I could encourage, again, if I was giving the year of 2017, what if we all just innovated in group visits, just tried it and learned from each other? That's the point of these communities, is to learn from each other. And I really think that, to answer your question, it solves the resource constraint, it's not expensive for people, and the majority of the value comes from the peer-to-peer interactions, which is exactly what's happening in mental health. It's a really exciting time.
Can I just add that don't stop having the conversations because you have an intuition that it wouldn't go anywhere. But at the same time, I think be respectful of where the patient is and what they're ready to receive. So, I mean, I've sometimes come across patients who tell me that after about 10 years, you are the second person who's mentioning this. And they remember because, this is something very different to what they're expecting to hear. So you have no idea when the penny would drop and when they might. And I really liked Sarah's point about resources, because I think anybody on this journey, you would end up, your max are probably filled to capacity with stuff that you have signed up and collected. And we have just, slip the Walls protocol when she's not looking.
I absolutely agree with that. You never know when the penny's going to drop something. You just never know. And it could be that you just drop it in there in that in that moment. Maybe for 5 years nothing will happen, and then you may not even know the impact that has 5 years later when someone else mentions it. Think, actually, you know what, I may try that, and we've seen that, and it's just do your best and do what you're doing. I was going to add to your point about the your colleague or your friend who is a bit sceptical. Like the paper which Dr. Singh put up about nutritional medicine as mainstream in psychiatry, which I think came out about March 2015 in The Lancet. And I remember clearly when it came out because that for me was one of those markup papers and keep it in your bank for when you need to have those sort of conversations, because suddenly The Lancet, this kind of prestigious medical journal talking about nutritional medicine as mainstream, suddenly that gives it a bit more weight. Should it give it more weight? No. Does it? Yes. So it's those kind of things that I think are worth keeping up your sleeve for those sort of conversations. But we've got time for one more question. I think you've had it up. Oh, sorry. We'll try and continue the conversation afterwards.
Thanks very much. My name's Nicole Freris. I'm a GP working in Islington, and I've been burrowing away as an autodidact in functional medicine and nutrition, and sort of broke through the fear barrier a couple of years ago. Thought, blast this, I'm just going to practice. So I started to, and it's been an amazing journey, and it's such a thrill to be here and feel that it's beginning to take off. And I would say that I think the NHS is, it's a different model, but it's a perfect model for functional medicine. And particularly in the context of general practice, you speak about communities, and you know, in a society whose fabric has been pretty kind of ripped apart, general practices still are their communities. You know, that's where people meet. So I mean, I feel that we need to identify the nodes where we can really focus and put all the evidence-based kind of developments of functional medicine. For example, I did a talk to GP trainers, and that then has a sort of kind of a ripple effect throughout, because then that maybe a few of them will then begin to clock it. So I think, and trainers meet twice, you know, a couple of times a year. They're also setting up sort of patient support groups. So, you know, getting all the diabetic patients or rheumatoid patients and just giving them the basics. I mean, I think the biggest impact really has been just getting people off wheat and grains, and, you know, just giving some basic nutrition advice, and that can be done quite easily in groups. So I was just wondering about, you know, thinking about the system, the NHS as a system, and just identifying those nodes in terms of the places where it would be most efficient for us to really put our energies and share the information.
Thank you very much for that. I guess that we've really got time for just one of you to answer that, about, you know, what are those nodes within the NHS which we can get a quick win on. I think is my summary of that.
I think in my experience, you know, I see possibilities everywhere. I mean, there is not a single setting where I feel I cannot slot this in. And again, it has to be judged. But again, so for example, from where I practice, there is, again, you know, we constantly have medical students coming in, trainees coming in. There are opportunities for teaching and training. And I think in a team like mine, I have got a lot of liaison with GPs. So last week I spent half a day at a GP surgery. And it's so interesting that what we were talking about, because I was describing one of their patients who was basically living on 36 cups of tea and coffee, having one meal. And that he has been doing that for about 17 years. And there was one GP that all the other GPs were pointing. He said, he does that. So again, I mean, that particular GP is probably not going to be on board. But again, using those interactions to kind of test the waters about where readiness is. But I mean, just like I said earlier, it's about having these conversations again and again, because people have literally come out of woodwork to connect within my own team, within the larger organization, as well as people outside. And can also mention about patient experts. I mean, in any policy work or strategic meetings, there are patient representatives, and you know, they just naturally connect to this message, and they have huge influence where change is required, and I think they can be recruited in spreading the message as well.
Thank you. And I thought it was a great story that you finally built up the courage to start practicing this way. And I think there is a huge load of healthcare professionals out there who feel the same way and are just lacking that courage. And I think it's meetups like this that are actually helping engage this movement.